I want to let you all know that today's panel will be recorded. All participant lines will remain muted, but you are all encouraged to submit questions through the Q&A or chat feature, and we'll do our best to group similar questions and address them if there's time before the end of the session. Thank you again for attending today's important discussion on the behavioral health workforce here in Washington. As we've seen, particularly during the COVID-19 pandemic, having a well-trained and robust behavioral health workforce is key to having healthy communities. But unfortunately, we are currently facing record workforce shortages in this field. Thank you again to the MolinaCares Foundation and the University of Washington School of Nursing for bringing together today's expert panelists who are joining me. So I would first like to introduce my good friend, Dr. Azita Amami. Dr. Amami is the Executive Dean of the University of Washington School of Nursing, perennially one of the top nursing schools in the nation, where much of her work has emphasized the increasingly global nature of nursing and the importance of educating nurses to deliver care in a wide variety of culturally and economically diverse settings. Dr. Amami earned a bachelor's degree in nursing from the renowned Karolinska Institute in Sweden. Her academic leadership experience spans 2 countries and 25 years, including a stint as the Dean of the College of Nursing at Seattle University. And her research has resulted in more than 70 publications in peer-reviewed journals around the world. Dr. Amami, welcome. I'd next like to introduce our partner at the state, Sue Birch. Sue serves as the director of the Washington State Healthcare Authority, the state's largest healthcare purchaser. Appointed by Governor Jay Inslee in 2018, she oversees efforts to transform the healthcare system and ensure Washington residents have access to high-quality, affordable care. Also a nurse by training, Sue is passionate about improving population health and reducing over-medicalization by focusing on the social determinants of health. Prior to leading the HCA, she served as the executive director of the Colorado Department of Healthcare Policy and Financing, where she led the successful implementation of the Affordable Care Act. And finally, well known to all, we have Representative Eileen Cody, the chair of the House Healthcare and Wellness Committee in the Washington State Legislature. Representative Cody has worked for many years for improved patient safety, mental health parity, public health services, and to restore the universal purchase of vaccines. She has also led efforts to implement the Affordable Care Act here in Washington. Representative Cody is a neuro rehab nurse and recently retired after working at Kaiser Permanente in Seattle for the past 40 years. Welcome, and thank you all for joining me today. So our first question is for Dr. Amami. Dr. Amami, we've seen COVID-19 have a significant impact on the healthcare workforce as a whole. Clinics and healthcare facilities across the country are seeing a shortage of nurses, doctors, licensed clinicians, and support and ancillary staff, as some are simply walking away from their positions in healthcare. Dr. Amami, how has this impacted the healthcare workforce overall here in Washington, and in particular, behavioral health?
This is a very good question, Jay, and thank you very much for inviting me to join this very important event. So I would like to say that pandemic impacts have been enormous on frontline healthcare providers and ancillary staff, such as burnouts, increase, financial and family life stress or PTSD, to name some of them. Like the rest of the country, we in the Washington state were short of nurses in all areas, including behavioral health, before the pandemic. The pandemic has increased the demand for behavioral health services, which is far outpacing the supply of qualified workers to provide services. Health inequity has also worsened, particularly given how BIPOC communities have been disproportionately impacted by the pandemic. Since the pandemic, many nurses have left or said they intend to leave the workforce. One survey of 500 nurses statewide found that 42% of them are considering or have already made plans to leave the workforce. National data suggests the numbers is even higher. Today, one online job board shows more than 700 openings for behavioral care nurses in our state. Hospitals and other healthcare facilities are competing against each other and against out-of-state facilities that are offering substantial bonuses for even temporary help. The underlying problem is educational capacity, however. There is substantial gaps between the need for behavioral health nurses and our capacity to graduate nurses with the required skills. This year alone, our school had more than 10 applications for every available slot in the entering classes. There are many people who want to be nurses. And keep in mind that only a percentage of our admissions will opt for a behavioral health specialty. Increasing the nursing workforce depends on increasing our capacity by removing the giant clinical placement and faculty shortage roadblocks. And they prevent us to grow our programs and to educate more nurses, including behavioral health nurses.
Sue, thank you very, very much. Excuse me, Dr. Amami, thank you very, very much. Sue, I will ask you to expound a bit on that. What are some of the unique challenges facing healthcare workers, especially those focused on behavioral health in our state today?
Well, Jay, I think certainly in Washington and across the country, we're seeing an increased societal awareness around the prevalence of behavioral health conditions. I think people are more aware of the availability of services and treatments. And there's an enormous decreased stigma. I mean, when you think about just recently the work that Lady Gaga and others are doing and how it is becoming acculturated into much of our entertainment, behavioral health is really coming to its forefront, which has been sorely needed. So I think there's been a real societal awakening. I also think that the Affordable Care Act and the mental health parity laws have really expanded coverage. And so we're seeing whole populations of people really need greater intense behavioral health services. I think clearly the pandemic, the factors related to, the pressures of all the intensity of the pandemic, as well as kind of what was playing out, led to kind of a perfect storm. I also think that, the access and staffing challenges across all care settings, as Azita had just remarked, as behavioral health is becoming more integrated, it puts stressors at nursing homes and hospitals and school nurses. And so it's really hit across the continuum. And I think that's a good thing and bad thing. I think in a lot of ways, as we're going to hear and discuss today, we're going to really have to change the concept of multidisciplinary teaming and also the way we're training people. And I know Azita and I have some creative ideas about what to do for all those slots that aren't filled. How can we repurpose those applicants, get them working in kind of an apprenticeship model or in other careers that bring them back in to a nursing path? So those are just some of the contributors.
Great, thank you, Sue. Same question to you, Representative Cody. As a nurse, what are some of the unique challenges you see facing Washington's healthcare workers in today's environment, specifically in behavioral health? I'm going to say your favorite thing. You're on mute. Representative Cody, you're still on mute. We cannot hear you.
God, here I am talking about. I said you had 3 nurses here, and we're all got similar viewpoints, I would say. Right. But I don't have a lot to add, but I will say that since I retired before COVID, I just want to say that part. So I don't want to blame COVID, but everybody that I know that could retire has retired, being one of those baby boomers that's at the retirement age, and that that was unfortunate that COVID came along and helped encourage us to retire if we could. And also, I think that COVID has definitely decreased the stigma of accessing behavioral health, because everybody is understanding the stressors that they and their family and their friends are under. And so we don't see quite the stigma associated. But also, we've had the racial reckoning that has included that we realize that police should not necessarily be the first responders all the time, which has expanded our need for behavioral health workers. And I'll say that the shortage of behavioral health and nursing was here before COVID. So it has just expanded the problem. We've talked about the numbers of worker shortages that we have. I heard from the Hospital Association in a meeting just before this one, 6,000 not FTEs, but individuals. So either part-time or full-time clinical that they need. So that's a lot of nurses to try and start catching up on. And that's just on the nurse side. Then if we just look at the counselors and all the behavioral health workers we need. Right. So we are definitely behind. And playing catch up is not an easy thing to do during an epidemic. So but we just have to face it and continue to try and figure out how we're going to do it.
Well put. It's a crisis, no question. And that's one of the main reasons we're here today. Dr. Amami, what role specifically have nurses played in addressing the behavioral health issues that have been exacerbated by the pandemic?
So as we know, nurses are often in the front line and would be able to identify behavioral health needs and responding to crises in many, many different settings. And remember, chronic medical conditions are exacerbated during the pandemic, as my colleagues just suggested, by social isolation and lack of access to behavioral health care. Often overlooked is the fact that advanced practice nurses are serving as independent primary care providers throughout our state. Increasingly, nurses are serving in roles around care management and specifically behavioral health care navigation, helping patients access behavioral health and other community resources. That's therefore important that these nurses have behavioral health knowledge and skill, because they are often the point of entry into the healthcare system for people in remote, rural, and tribal areas. Just an example regarding the opioid crisis, we are seeing the expansion of nurse-led team-based opioid use disorder treatment models that are also known as office-based addiction treatment models, and that has shown to be very effective. But there is also a need for specialists to whom these frontline nurses can refer people who are dealing with healthcare crisis and mental health crisis. The challenge is that we do not have enough people in any of these categories. And throughout the pandemic, those with existing mental health issues often saw them become worse. So the severe shortage of all mental health professionals, as my colleagues shared, has been exposed by the pandemic, but this has been a kind of crisis even before the pandemic.
Right. Thank you. Again, well put. Next question. The COVID-19 pandemic has had disproportionate impacts on communities of color, low-income communities, and other groups that experience health disparities and health inequities, which has resulted in increasing impacts on the Medicaid population. Sue, how has this affected behavioral health during the pandemic, and how have provider organizations worked to overcome and address these disparities to provide high-quality behavioral health care?
Yeah, so Jay, and to my co-presenters first, I think we all have to continue to thank and recognize what Herculean efforts occurred to get us through the pandemic, and we're not through it by any means. And there's no question that our BIPOC communities have really, COVID laid bare so much of the systemic racism and the challenges. And obviously we had so many other intermingled things going on in our country. So I really think that we've come to this recognition of the importance of the social determinants of health. And some people ask me not to use the words over medicalization, but we have forgotten, nursing has not, but we as a society has forgotten kind of the social role that goes on. We have to worry about health and well-being. And I believe that really recognizing this pursuit towards health equity and really understanding the health equities at this moment in time is really critical. Unfortunately, we don't have good data systems for a variety of reasons that really parse out the data we need. But provider organizations have really been striving to come alongside and really deal with health equity by looking at kind of what sort of systemic, aligned, strategic priorities can we make to really tackle these issues. I think the investments in the right resources, and we thank Molina for your investments that you're making in this area, realigning the infrastructure at the federal and state and local levels, and then really making sure that we have kind of all the provider entities pulling in the same direction. Our accountable communities of health and public health, when you think about how strained they were, but how important they were, knowing which church communities or which neighborhoods, really knowing kind of our communities at the local level, really, really important. And I would argue that we know about hospitals and ER use, and oftentimes we've over medicalized the system, and we've got to have this new focus on really understanding social determinants, well-being. We also have to keep recruiting BIPOC clinicians and growing kind of more of our own, especially in rural frontier areas. And then lastly, I'll just say telehealth is going to be really critically important. And, telehealth is really tricky, though, if we don't have communities that have broadband access or don't have families that can even afford phones or pads, and how are we going to make those connections more uniform? So these are all areas that we hope that the legislature will align with some of the governor's leadership around this health equity pursuit, but very critically important to get at all these points and to make sure we really strengthen the social well-being side of what we're doing for people.
Well, I'll tell you, as a physician myself, I don't have any problem with the term over-medicalization being used, because I think it's actually very appropriate. When I was working as a family physician at the 45th Street Community Health Center, taking care of people on Medicaid or with no insurance, very frequently I'd walk into a room and say, you need to talk to me for about 5 minutes. You need to talk to much more a social worker, a behavioral health worker, and a nurse. I think there is, I think moving away from the over-medicalization is not a bad thing at all. Representative Cody, we know that good public policy and providing high quality healthcare to all Washingtonians go hand in hand. And just last week, the state's Workforce Training Board released a report stating that Medicaid reimbursement rates in behavioral health are still too low, despite recent increases. How is the state legislature continuing to address this behavioral health worker shortage and the reimbursement issues?
Well, actually, I'm glad you brought up the workforce training report, because first of all, I wanted to remind everybody that that group actually recognized the need for more behavioral health workers in 2017, and that's when we formed the behavioral. It was from a workforce assessment, and then the legislature directed to have a further assessment and a work group. And so from the recommendations there, what we have done, I want to kind of outline that first. We did $150,000 of general fund state to provide the authority to convene a work group to develop recommended teaching clinic enhancements, a rate for behavioral health positions and for agencies, so that we can train more behavioral health workers and get the agencies that have to supervise those people the money, so that we can get more workers in that regard. HCA must establish a workforce pilot program and supply grants for community mental health and substance use disorder treatment providers. And these grants must be in a partnership with Accountable Communities of Health and the University of Washington Behavioral Health Institute. And the purpose of the program is to provide incentive pay for individual services, clinical supervisors within community behavioral health agencies, state hospitals, and facilities operated by DSHS. Then we have $2 million that were appropriated, without $1 million state and $1 million federal appropriated for health loan repayment programs and grants to hopefully increase the number of people. And we have another 5 million, I think or so, to put into the professional loan repayment and scholarship program account. Then we passed other legislation about supervised experienced hours, so that a person that is pursuing a license as an independent clinical social worker or advanced social worker may complete through distance supervision. That's the telehealth discussion that Sue brought up. And we also extended the time for substance use disorder professional during COVID, so that they could grant a waiver for additional credentialing time, so that they don't have the barriers to get their testing done. And we started a new apprenticeship program on behavioral health, and that's actually, it's just getting started. I'll say we passed the legislation for it and it's being worked on now. So those were the things that we have done. The things that, as you mentioned, the next recommendation that came from the work group was that we should look at a 7% increase. We did a 2% increase for providers last year, but they feel that we still need to do a 7% increase to be able to get enough funds for the clinics to be able to, or the community health clinics to be able to actually hire and retain providers. So I can't say that it's going to happen, but I know that it's a big push and everybody seems pretty unified on that amount.
Great. Thank you, Representative Cody. So I'm pleased to announce today that MolinaCares and the University of Washington School of Nursing are partnering specifically to develop and implement a new family and psychiatric primary care curriculum for nurse practitioners to address the behavioral health workforce and capacity crisis in Washington. Dr. Amami, can you please tell us a little bit more about this partnership and how it will help address the workforce shortage we've been discussing this afternoon?
I will be very happy to. This is so exciting, and thank you, Jane and MolinaCares for your support. So as I mentioned earlier, the role of primary care nurses are often overlooked in regard with addressing behavioral health issues. And Jay, I am a strong proponent of investing in prevention and health promotion in timely manner. I believe that if we would address the health and social issues in a preventive manner, we could not only avoid tremendous health and social crisis and costs, but also we would strongly improve the overall health outcomes in this country, in the United States, to be able to reach the level of other OECD countries in their health outcomes and costs. Leveraging the primary care services to become the preventive gatekeeper for many acute and chronic health conditions is a very smart step in the right direction. Another important step in right direction is removing the silos across the organizations that in one way or the other play important roles in the healthcare industry. So partnership is the key to work in synergy for impactful and productive changes that can help us addressing some of the most challenging health issues in our state and beyond. And I'm very happy to share with you that the MolinaCares and University of Washington School of Nursing partnership intend to do exactly that. Our partnership with MolinaCares is about promoting behavioral health and make behavioral health care services more accessible and timely for all people. We are so lucky to have like-minded healthcare organizations like MolinaCares that not only share our vision and the sense of urgency in regard with behavioral health crisis, but also is willing to support us and partner with us to intervene and overcome the challenges in a meaningful and action-oriented manner. As workforce needs are shifting, particularly the role of nurses and nurse practitioners in the care teams, we need also to re-envision nursing education to prepare nurses to be capable of addressing the current, needs that we all have been talking about today. With MolinaCares support and partnership, we will develop now a curriculum that will prepare nurses to help fill the gaps of the workforce shortage across primary care, acute care, and behavioral health care. And the certificate in psych mental health nurse practitioner will be enhanced and made available to students in other nurse practitioner tracks in very efficient way. Students in our DNP program can then seek dual certification as a primary and acute care provider with additional certification as psych mental health nurse practitioner. Providers with this preparation is crucial to rural and underserved communities, as these dual certified nurse practitioners can provide high quality, comprehensive, holistic and integrated healthcare and serve as integral expert in bio-behavioral health as members of the health care team. So in short, as I shared earlier, there's a significant demand for nurse practitioner trained to monitor and treat depression, anxiety, and suicide and other areas in the mental health care, utilizing evidence-based treatments. We also know that in order for the healthcare services to be effective, the workforce need to represent and mirror the diversity we see among our healthcare recipients. And this new curriculum commits to really address these very important two areas. So thank you again, MolinaCares, for your tremendous support and commitment to address this very, very difficult and challenging crisis that we are facing.
Well, it's very exciting, no question. And Dr. Amami is too humble to add. One of the things that I'm the most excited about is the University of Washington School of Nursing is hands down a national leader. And this program is hopefully going to be emulated, and we're going to be able to see some really real important growth in this area. An important part of the new family and psychiatric primary care curriculum will be to ensure nurses have training in remote behavioral health technology. A report released just last week by the U.S. Department of Health and Human Services found a 32-fold increase in behavioral health care delivery through telehealth during the pandemic. Sue, you already touched on this a bit, but how can telehealth help address the capacity issues we're seeing in the behavioral health workforce today?
Yeah, so Jay, there's no question that the silver lining in COVID was the massive uptake and use of telehealth. I am really proud that Washington Healthcare Authority stood up 2,000 Zoom licenses to behavioral health providers. We have literally helped facilitate millions of minutes in counseling. And every time I run into my emergency room friends, they say, thank you for keeping people where they needed to be, because we need services going on in other environments. So these virtual visits have really been a remarkable step in healthcare evolution. Obviously, barriers to accessing care drop dramatically. There's more on-demand opportunities for same-day appointments. There's brief interventions and evidence-based treatment that can go on. And also, I think it's really important for us to remember, we got to get out of this mindset that we're always doing to the patient or for the patient, but patients and clients can also have access to more self-management tools as primary prevention and or complementary care planning techniques. And we've seen that. And obviously the University of Washington has some very interesting work going on in this area as well, as far as apps that are being used for our behavioral health populations. I think, again, we're going to have all of this opportunity to, how are we going to really teach that integrated team care delivery, and how are we going to make sure that the telehealth skill sets that we need, we've got to get really artful about some of this work, and it will come into alignment. Lastly, I'll just say the state has a new role, and our federal partners really recognize this new role. Before, through our high-tech investments, things like electronic health records were put in the hands of hospitals and physician practices. And we are quickly seeing how important it is to connect in these other non-hospital or community-based entities. Imagine how powerful it would be right now if our entire state was on a very aligned electronic health record or community information exchange platform where we could be monitoring for symptoms of Omicron and or doing more genetic testing of things that are going on. And there's so much more rapid speed to care when we have aligned data sharing. And I will also remind people that Washington played a massive role in the Pacific Northwest. We took the spillover from our neighboring states who went into crisis standards of care. We helped with all the movement in the region, and I continue to harp on my federal partners at CMS about how we have to have these advanced telehealth capabilities. We have to know where our ICU nurses are, where our behavioral health nurses are. We have to be able to track this so that we can move clients. It's only going to get worse too with when you look at some of the global climate impacts recently with all the flooding that occurred in our Puget Sound area. We have had real issues with getting opioid treatments to our clients that were stuck in flooded areas. And so we're really pushing on our federal partners in a new way to say, we got to be better. We got to step up our game. We can't be complacent. We've got to tie in these electronic telehealth resources and really have the training and sophistication in all of our students and our professionals that are coming out.
Thank you, Sue. It's great. Another focus of the family and psychiatric primary care curriculum is to train nurse practitioners to provide wraparound and comprehensive care in community settings like supportive housing. Dr. Amami, why is it so important for the behavioral health workforce to receive training in these settings?
This is a great question, Jay. And I think that we all agree that community-based care has long been a foundation of nursing. It's therefore crucial that nurses and other behavioral health workforce gain a strong understanding of the intersectional and contextual nature of health and social problems, and the necessity for an approach that does more than address them as a series of separate issues. For example, we know there is a correlation between significant behavioral health disorder and homelessness, which underscores the critical role of training that involves social determinants of health, as Sue has alluding to very eloquently, and embracing the fact that housing is critical to health. It also exemplifies the model of providing care where the patient is and addressing where the patient needs care. Preparing nurse practitioners to provide community-based wraparound care is critical for at-risk populations, particularly for our most underserved communities that have significant social determinant of health challenges, whether it be racial injustice or housing, transportation, childcare, or a language barrier, and so forth and so on. So supporting housing settings are among the most complex healthcare challenges because residents very often have multiple physical and mental challenges that interact and amplify. So it's very important for the healthcare providers and nurse practitioners. That's why this new initiative will be very important to focus on strengthening the knowledge for nurses in primary care to really, be able to put the people's, problem into the broader context than only, medical care. So I really believe that nurses are particularly very good at looking at the whole patient and the whole situation and see the big picture rather than just, seeking to solve a specific problem at a time. So that it's absolutely imperative that we broaden the nurse practitioner scope and training similar to how social workers are trained to address behavioral health in the context of systems such as the racially framed system, housing system, criminal justice system, school system, and so forth and so on. Because the system, a systemic approach to providing healthcare will really help us to be much more effective and much more, providing much more meaningful care to people in need.
Great. Thank you, Azina. Speaking of comprehensive wraparound care, one of the cornerstones of this new curriculum highlights that one of the most effective ways to address and manage behavioral health issues is to integrate standardized screening and evidence-based treatments of behavioral health conditions into primary care. Representative Cody, why is it so important that we make this a priority in educating our future healthcare workforce?
Well, when I think about this question, I always remember, I'm going to quote former Representative Tammy Green, who was a psych nurse herself. And she always talked about how we had to get away from the Marie Antoinette healthcare that we have been historically providing, and that the head is not a separate part of the, it's not separate from the body, that's actually attached. And so that's what I think of. And I think also of my training 40 some years ago as a nurse, where, we had a psych rotation and didn't really talk about behavioral health much in the rest of the rotations. And I hope that that is not the case, although I think it has not changed enough in our education systems. And I'm hoping that this new program will help change that for not just the master's level, but bachelor's and associate degree level also. We need to see it change in all levels of education. But as you said, healthcare workers need to be prepared to treat behavioral health and the same as they do other providers, other vital signs. And also that it's been shown that organizations that do screen, do standardized screens have better outcomes, and I have done much better on that. And I can say in my own practice, I remember when we initiated doing the depression screen on the medical assistant actually did it, didn't require a lot of training. The medical assistant did the screen for everybody when they were checking them in. And if they scored a certain level, then they went to the suicide screen. And I remember the first time we had somebody that was actually suicidal in the clinic, and we actually had to figure out, now what do we do next? And that it was all a very good process, and actually I could say improved our care considerably, so that we recognized that actually this was something we needed to be paying attention to. So I think that those are just examples that we really need to see behavioral health just incorporated into all of healthcare.
Yep, that's a great example. And the proliferation of evidence-based screening tools and treatments has really advanced in the last 10, 15 years. So
Yep.
It's great to see, and both in the provider setting, but also in the training setting, to see those things really kind of baked in. So throughout the pandemic, Molina has been focused on helping ensure our state's behavioral health care workforce has the ability and training to treat their patients effectively. And in addition to providing the ongoing support and partnership to our statewide network here in Washington of over 175 different behavioral health care providers, we've also provided substantial additional and specific philanthropic support to some providers, and I want to mention a few of those. We've collaborated with Compass Health in Snohomish County to support their Broadway campus redevelopment project to provide additional permanent supportive housing, as well as inpatient and outpatient intensive behavioral health treatment in Everett. We've also created an exclusive partnership with Spark Peer Learning Center in Tri-Cities to sponsor a 6-week youth behavioral health peer counseling training program. We funded 2 programs with our friends at Excelsior Wellness in Spokane. The first, called Meet Excelsior, serves youth in need of behavioral health treatment by connecting them with necessary resources, including around social determinants of health and peer support. And the second, the Excelsior Equity Scholarship Program, funds educational opportunities for Black and Indigenous people of color enrolled in advanced degree programs in the fields of education, criminal justice, and healthcare. Lastly, we've also provided this year, partnered and provided funding for the Seattle Children's Hospital Ruby program, which gives parents and caregivers evidence-based training on how to decrease challenging behaviors in children with autism spectrum disorder and help improve daily living skills. Now, I want to ask one last question and hear from everyone on the panel. We've talked about the behavioral health workforce capacity issues here in Washington and how we're all working to address this, and to ensure our nurses, doctors, other clinicians, specialists, and providers around the state have the support and the funding they need to provide the best care. As we continue on this journey, how can providers, payers, other sectors of the healthcare field collaborate to support our workforce, and what would you like to see from the industry as a whole, government, or other stakeholders? Let's start off with Sue.
I almost forgot to unmute. Well, you know, this pandemic has gone through so many different phases. I think you all remember when we began, it was kind of the crisis of where we don't have supplies and we didn't have information. And now we are in the workforce crisis phase. So HCA's got to support workforce development and academic program development that promotes and ensures this whole person care for the integrated physical and behavioral health care. And I can't thank the legislature enough for the years of work that has been done to build up integrated care delivery. That is still in progress. Somebody said, didn't that get done? And it was like, it's not ever going to be done. It's always evolving as we learn to work together differently. But I think, you know, as Molina and the UW work shows, and certainly with the commitment that's being made, we've got to have this continuing emphasis on team-based care and this opportunity to do things differently in the academic and the workforce space. And RNs and our ARNP's roles have to keep maturing and have to be played out. I personally think that in team-based cares, the leadership, oftentimes, you know, I've seen in hospice care as well as other multidisciplinary teams, it doesn't really matter which discipline takes the lead, as long as they have the principles and the foundational pieces that nurses really are trained in. So it's why we oftentimes see nurses really getting so into this space so effectively. We're really interested in how we can keep facilitating the flow of financial resources and the technology, the IT tools for patients and families and communities, systems and whatnot, for all of that to come together. I do think it's really important to note that our investments in the work around primary care redesign are critically important at this moment in time. Our successful award of the CHART Rural Transformation Activities funded by CMMI, and then our Medicaid Transformation Project extension, which was just granted a 1-year extension, and then we hope to move on renewal into another 5-year period, really helps us evolve the roles that different disciplines play and how it can strengthen the presence of more nurses and ARNPs. So those projects are really important. And if I could just share a personal example, I have a pretty amazing niece who is a nurse, did a lot of travel nursing, and has now really stepped into getting her nurse practicing. And she has said, I am so interested, having come through COVID, in becoming a psych nurse, but I still want to do some more primary care. And I was, you know, assuring her that, no, you can do both. I also have a brother-in-law who has a significant late life bipolar diagnosis, who was an extraordinary quality craftsperson, had a building company, and he is probably the most important team member on a multidisciplinary team, because he works on housing supports and that wraparound care and triggers the nurses and the docs and gets ahead of the problems when he sees clients. These are the kinds of things that HCA has to help facilitate and have to help put together. I think we've gotten so stuck in our silos of excellence, and Azita, the UW School of Nursing, is a great example. We have to keep looking at this cross-sector work. And I also think that our legislative leaders have to get a little bit more comfortable for us to explore these workforce options, apprenticeships. Really, what could we do to have a paid staff member that takes all of the applicants that don't get in on the first time into nursing schools and think about how can we offer them these different tracks. those are just some examples. Lastly, I'll just say Department of Health, I think sometimes the traditional licensing issues and some of the over-engineering that has occurred over the years, we've got to rethink how to streamline, be nimble, be more responsive. We've seen other states move much more quickly and move resources around. So really important, especially for our partners in managed care, where they've done really pretty amazing work throughout the pandemic, and certainly stepping up to this place and recognizing that, boy, we got to really all lean into behavioral health. So we think that, again, with this aligned commitment towards workforce enhancement and continuing healthcare system redesign, that we will be able to really improve the health of all Washingtonians.
Thank you, Sue. Dr. Omami.
Jay, I am a true believer of it always takes a village for anything. And I think that it's very important that we work in tandem and collaboratively and share the responsibility, the vision, even the identification of the problem. And I am so excited because we are really doing great things. I can just give you an example about my collaboration with these two leaders here that we have come together and have discussed a lot of variety of issues that before getting connected with them, I thought that I was the only person having to deal with those issues, and very quickly found out that these are the problems that are shared by a lot of people. And it's just a shame if we try to solve them in silos. And so I always advocate for synergy, for working in alignment and cross-fertilization, because then we can really come together and use our resources in the most effective and best way. I can just give you an example. I cannot alone solve this problem with growing and our programs to prepare more nurses if our partners, clinical organizations partner, won't be open and participating and partnering with us to solve this clinical placement challenge that we are facing right now. I really believe that complex and long-standing problems requires complex and long-standing solutions. And we need to come together and partner with each other exactly the way that we have now done with MolinaCares. This is a wonderful example that together we are much more capable of addressing challenging issues.
Very, very wise words, Azita. Thank you. And I think probably most of us on the call know that Washington is definitely a leader in collaboration. There's no question. Representative Cody.
Well, I'll just talk first about what hopefully the legislature might do to help us out in this next session. And I think the first thing, as I said before, I cannot commit to it, but I do know there's a lot of interest and support for the increase, 7% Medicaid rate increase, and for the grant program. So that's where I would hope that we're going to put some of our dollars. Although I will warn everybody that I think that the increased revenue that we have seen and was in the forecast, I've probably, at least 7 times had it spent by all the different interests. And that's just on the healthcare side. So you can imagine. But I certainly do support that we need to do a Medicaid rate increase. And I want to see in the grant program to also offer retention incentives, because I think that we're seeing so many people, especially in the behavioral health system, bouncing around. So we really need to support those that we have so that we can keep them in behavioral health. That they have a lot of skills and probably can go into a lot of different fields besides, having to deal with individuals with behavioral health problems all the time. Hopefully they went into it so that they could, but money sometimes talks. And the other thing is, and Sue, I think, mentioned it, but I want to see us continue working on a statewide adoption, which I think takes some Medicaid waivers, you can correct me if I'm wrong, for the certified community behavioral health clinics so that we can try and mine some of that federal gold and increase rates there. And actually, the other good part about that is it's such an integrated picture of having not just the behavioral health, but primary care has to be in the facilities also. So that's some of the things I want to see the state do. When I think about other providers, I guess that I would like to see, and this is a long range because I've been complaining about it for a long time, the hospitals stepping up and having more behavioral health providers employed in the hospitals, because I just can't imagine that anybody would accept going to an emergency room with a broken leg and it can't get fixed, can't get set. But you can go with a behavioral health problem and not really get a lot of help. So those are the things that have upset me about our care system for some time that I'd like to see change.
Yeah, great points, all super important. And I would just add, look, we all know there is no one answer to these challenges. Apprenticeship programs, innovative loan repayment programs, increases in the adoption of peer and other community-based workers, modifying state administrative requirements, value-based payment models. We've talked about a lot of these things. There are short-term, there's medium-term, and there's long-term work and strategies that need to be undertaken. This is going to be hard work. This is not going to be easy. But many behavioral health leaders across Washington believe, and I agree, that we need to aggressively pursue what you were just talking about, Representative Cody, adoption of the Certified Community Behavioral Health Clinic model, also called CCBHC. We didn't get into the details today, but it's a demonstration project happening in at least 10 states, and there is enhanced government provided funding, very similar to the community health center structure that we have now. This is one of the key answers to long-term sustainable changes to help support our community behavioral health providers. And it's really a way to substantively and sustainably and positively transform the financing structure for community behavioral health in Washington. So I know there's going to be a lot of pursuit of that moving forward. There's just a lot of great opportunity before us. It's going to be a lot of hard work, but I'm a cup half full type of person, and there's a lot of opportunity. I know those of us here and many others on the call we're up for the task. So we have a time for a couple questions here. I know a few have come in, so let me get over to the chat here. Here's one. I'm not sure if Sue will be able to answer it. Is HCA considering adding more high acuity behavioral health codes to the HCA fee schedule? For example, intensive outpatient, which is something that can also be delivered via telehealth, and can serve possibly as an alternative to in-person residential or inpatient treatment.
Yeah. So Jay, as you suggested, I can't answer that specifically. I do want to dispel one thing. I think oftentimes people think, oh, if the legislature just gives us more money, if you open up a code, it will just happen. That doesn't happen. We have to build the workforce capacities. We have to have the appropriate policies, procedures, approvals, and whatnot. But we are absolutely exploring this kind of continuum of services where they're most appropriately provided. But again, it's what we've already learned in the Affordable Care Act is oftentimes we have to lift on these resources in tandem. It's not just a linear progression of do one thing and then these other things fall into place. So it's obviously the focus of this phone call, this presentation, but we have to have the commensurate changes going on in the academic and workforce settings as we modernize and move kind of the regulatory and payment environment.
Right, well put. And I think another thing for all of us to remember is some of these things, I'm impatient. I'm a family doctor. I'm used to people coming into my office and I can tell them what I think they need to do or treat them right then. And these things in the administrative bureaucratic world take a long, long time. And this is a great idea. There's a lot of ideas like that. They've been discussed. We're going to keep discussing them. Administrative changes. When I was talking to the leaders at Excelsior, which I mentioned, they're one of the innovative programs we're supporting. It's not reimbursed right now. I said, well, let's support it, and then let's work with HCA and the legislature and make it reimbursed so it can happen all over the state. So youth in crisis in primary care can get the right treatment, so they don't end up in the crisis system. So the spirit is there. It's going to take a lot of hard work. Another question. I guess all of us could try to take a stab at answering. Do we foresee the standardized tools that we've been talking about in behavioral health screening and treatment penetrating barriers to care in communities of poverty and rural areas. Anybody want to take a stab at that?
Well, I would just say that that when they're standardized, that the measures are the same whether for wherever you're living. And I think it's one of the things that we really do need to work on is more standardization on social determinants of health and having everybody working off the same. This is Sue and I have talked about this. It's like we have so many programs. Commerce has housing, you know, the things are in different places. A lot of the same people are utilizing those. I mean, homeless people probably need food. They have healthcare problems. They, you know, so we have them in a lot of different programs, and it would be great if we could have all of those programs talking the same language in social determinants of health. So that's one of the things that I would like to see us move forward on. But I would say on the evidence on the screening that it's done for everybody. So yes, I think it'll go into rural areas too.
Yeah, and
Go ahead, Sue.
I would just piggyback on that by saying, I think when we see large systems have more advanced tools and small organizations not have the same type of tools, it creates more of this systemic kind of bias that goes on. And so I think the state and the feds have now really agreed that the state has a higher duty and role to play in tight, coordinated case management. This is really going to be a significant issue as we are modernizing the criminal justice system and releasing those that were probably very inappropriately housed in prisons for their mental health conditions. And so I do think we have a real opportunity going into this session to really step up Washington's game in the IT space. Community information exchange, critically important. Electronic health records that really hit across the state to far greater than just hospitals. And it, again, I have been so pleased to hear the awakening that our federal partners have had about put in a request. So if we can pull, as Eileen says, that magic federal money and then get the appropriate state match, that will go a long way to even out services so that we reduce the health inequities.
Great, thank you. Well, I want to be respectful of everyone's time. It's 1 minute before 5 o'clock. I want to thank each of the panelists so much for joining us for this important discussion today. And thank you for all the critical work you do with your teams every day at the University of Washington School of Nursing, in the legislature, at the Healthcare Authority to improve the health of all Washingtonians. And I also want to thank everyone in the audience for tuning in and asking great questions. I'm sorry we didn't get to all of them. And to thank each one of you and your teams for all the work you do in the communities. You can learn more about Molina's work in Washington and find a recording of this conversation by visiting MolinaCares.com. Thanks, everyone. Thanks again for your time. And let's get a lot of work ahead of us. Let's keep it going. Have a great evening.